episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
So, as a little background to today's episode, the term neuromodulation is broadly defined as the alteration of nerve activity through targeted delivery of a stimulus, such as an electrical stimulation. It can be a chemical agent to specific neurologic sites in the human body. Ultimately, these techniques are carried out to normalize and or modulate tissue function. It is an evolving area of therapy that can involve a range of electromagnetic stimulation, such as a magnetic field or an electric current, or even drugs in certain areas. Emerging applications involve technologies for gene regulation and optogenetics. Current existing neuromodulation treatments include applications in areas like medication-resistant epilepsy, chronic pain conditions, loss of sensory deficits in terms of hearing and vision. Some of the more futuristic areas that neuromodulation is being investigated in now include chronic conditions such as Alzheimer's disease, depression, recovery from stroke. We're joined today by Dr. Amilcar Santos, who is a practicing psychiatrist, the psychiatry service of the hospital Via Franca de Xira in Lisbon, Portugal, with expertise in neuromodulation, neurostimulation, the care of acute patients in the hospital, psychiatric emergency service, electroconvulsive therapy, and psychoeducation in bipolar disease. Dr. Santos has a degree in medicine from the Faculty of Medicine, University of Lisbon. He also did postgraduate work in neuroscience there. And he also interned, interestingly, in the Department of Neurobiology at Duke University at the Nicolelis Lab, where he focused on brain-machine interface technologies, acquiring various skills for implanting electrodes in the brain and spinal cord, performing a range of research experiments on different organisms, looking at real-time analysis of brain activity, participating in spinal cord stimulation for both the treatment and reduction of convulsive activity in epilepsy. Dr. Santos is also a lecturer in psychiatry at Nova Medical School in Lisbon. Dr. Santos, thank you for taking the time to come on the show today.
Thank you for having me here in this show. It's an honor to be here.
It's a pleasure having you. Typically we start things off just by really giving our guests the floor for a little bit to talk about themselves. If you can just sort of take us back a little bit, sort of introduce yourself, who you are, where you grew up, and a little bit of sort of your background to how you developed interest not just in medicine and psychiatry, but also in some of these more cutting-edge tools of neuromodulation. I think that'd be a great way to start off.
Okay, so I'm currently a medical doctor and a psychiatrist in the Nova University of Lisbon and in the Hospital Vila Franca de Xira. I was born in an ex-colony of Portugal called Cape Verde. It's a small country in the Atlantic Ocean. It's an archipelago of 10 islands. And when I was 18 years old, I came to Portugal to study medicine. I studied medicine at the University of Lisbon. And I remember when I was in the second year of my course in medicine, a famous and a well-known neuroscientist and neurologist from Portugal that lives and works in US, called Antonio Damasio, published a book called Descartes' Error. And I was influenced by that book and intrigued by the story of Phineas Gage, this railroad worker that had this accident where iron rod hit him in the head and damaged the prefrontal cortex. And then he has this change in his personality. And at that time, there was no treatment for that, and he became chronically ill and with extreme change in alteration in his personality. So during the course of medicine, I would spend a lot of time reading stuff about psychiatry, neurology, and neuroscience. When I finished my graduation in medicine, I decided to study 1 year of neuroscience. So I joined this lab in Lisbon at the same university and I work with it, Professor Ana Sebastião and Professor Antonio Joaquim Ribeiro. And then where I study neurochemistry and release of neurotransmitter in hippocampal slices. At the time, I was in doubt if I would pursue a career in neuroscience or clinic basic research, or if I would join clinics and study the residency, go to residency to become a specialist in a specific field. So then I decided I would go to psychiatry, and I entered psychiatry here in Lisbon as well, in another hospital called São Francisco Xavier, and where I was influenced by a lot of great psychiatrists there, including Professor Miguel Xavier, for example, and Professor Guzmão, and Joaquim Gago, and Bernardo Correia. And then when I finished my specialty in psychiatry, I decided that I would go to another level and try to study neurobiology more deeper, and join a laboratory with brain-computer or brain-machine interface. So I applied to Nicolelli's lab in North Carolina at Duke University. And in the beginning of 2013, I started working there. I started by learning how to implant electrodes in the brain, how to implant electrodes in the spinal cord of the animals. Both surgery was, quite difficult at the beginning, but fortunately I was from a medical field, it was not that difficult for me. And then I learned how to run the experiments, to interpret the data, and he assigned me this work on spinal cord in epilepsy. So we can talk about this later. So, and then after a while, I came back to Portugal, and I resumed my clinical activity here in this hospital, where I'm doing clinical work in the inpatient unit and emergency room of psychiatry, outpatient clinic, and neuromodulation, basically electroconvulsive therapy, but I also do transcranial magnetical stimulation and call it TDCS, and call it the TMS, and also TTCS.
And if we begin there, I appreciate that background. It's an area like epilepsy, which you've been quite active in, which I was looking at the numbers this morning. I had forgotten. We have in the United States alone, I think the number is something like 3 million adults, 500,000 children worldwide. We're about 50 million. And, sort of thinking back to, I'm a pharmacist by undergraduate training. I don't know how much the pharmaceutical armamentarium has evolved in recent years in the area of epilepsy, but you've been active in this area in terms of okay, we have this disease, we have this underlying abnormal neural activity, and you had a very interesting paper a few years ago. It was entitled A Closed-Loop Brain-Machine Interface for Epilepsy Control using dorsal column electrical stimulation. Could you just briefly, if you would, walk us through a little bit of the state of where we are in it with epilepsy in 2020, sort of where we've come with the drugs, and then sort of how electrostimulation, neuromodulation, neurostimulation has arrived on the scene for it, and sort of where we are with the therapeutics that you're involved in, and specifically in the area of epilepsy.
So I can tell you about this research I've done there in the lab at Duke. So it was very interesting research, because at the time I joined the lab, they had a few years before, they published a paper about spinal cord stimulation to treat Parkinson's disease. So the work they assigned me was to use the same protocol to treat epilepsy. And basically, the protocol would consist as follows. So we implant the electrodes in the brain of the rodents. I'm talking about rats that would weigh about 200 or 300 grams. In this protocol, we didn't use mice, but okay, implant in the brain and the spinal cord. And then what we'll do with was to inject a drug in the animal called PTZ that would cause a seizure. And then we will apply these stimulus to the spinal cord to try to control or to reduce the brain activity. It was a challenge because I was using the 333 hertz stimulus that was similar to the one used in Parkinson's disease, but it was not working at that time. Although at that time in 2013 there were at least one paper using a modified version of spinal cord stimulation to treat epilepsy, but low frequency. So it was supposed to work with 333 frequency hertz. So, but at my case, it was not working. So I decided to use 1 kilohertz. At the time, it seemed very high. But I've searched in the literature, and they were using this spinal cord stimulation with kilohertz frequency to treat pain. So I said, okay, if they use it in pain, so maybe it would work in epilepsy as well. So it started working, and then there was another interesting change in the protocol. Since before the full-blown seizure, I could see in the LFPs, in the brain waves, that it would have a prodromic phase. So we talked to this computer engineer, computer scientist called Corrie, and he came up with this algorithm to detect the period before the full-blown seizure, where we could stimulate and decrease the seizure. So it was quite okay. Unfortunately, I had to leave the lab before the end of that experimentation, but they continue, and I left in 2014. And in 2016, the paper was published, and I also contribute to the work as well. Although there are some political stuffs around me, but this work it's a very interesting work, researching, because it's in a closed loop as well. Although besides those information that I gave you about the frequency and the prodromic phase, and it's in closed loop, so the idea is to record the brain activities, detect seizure, and then the stimulation to the spinal cord. Currently, this technique is being used to treat Parkinson's disease and in pain. In epilepsy, I'm not aware if they are doing clinical trials right now in humans, but this idea is interesting because the spinal cord is a highway of information to the brain, and we can reach. And what is interesting is this information that enters the spinal cord at that level goes through the brain and reaches the motor area and the sensory motor area as well. So it's quite potent way to reach the brain.
And continuing along that line of thought, and we'll talk about sort of information sharing a little bit, but the other, you're involved in a variety of, or you've been involved, and you still are involved in a variety of other sort of therapeutic areas. I know you're involved in anxiety, depression, spinal cord injury bit. And once again, sort of this underlying theme of neurostimulation, but sort of the sub-theme of what we'll call electroceuticals. We talked a little bit on the show in the past. Take us through, if you would, for a few minutes, or just some in the sense you're involved with a lot of different therapeutic targets, what are you most excited about in terms of specific diseases looking forward with these types of electrostimulation and neuromodulation tools?
Okay, there are several neuromodulation tools, and interestingly, the one of the oldest is electroconvulsive therapy. Mm-hmm. Although it's evolved in quite issues because of his history, but it remains a very potent therapeutical tool that can be used in a variety of psychiatric disorders, including depression, bipolar, some types of psychosis, catatonia, for example, and it remains very important. And currently, I'm doing this, applying these therapeutical tools here with my patients, and I can. I've been treating patients with, for example, catatonia. They have psychotic depression. With catatonia, some of them does not even move. They stay still at the bed. They don't leave the bed. They stay there. They don't eat. They don't talk, and they don't respond sometimes to our medication. And the only treatment available would be electroconvulsive therapy. So this is one of the oldest, but very, very, very important, because nowadays it's a modified ECT, so that there is no pain. The patient is anesthetized, and then the stimulus is delivered to the head. So we have this bifrontal, bitemporal, or unilateral, and we can change the frequency of the stimulation and the pulse width and different kinds of parameters. So, and we can deliver the stimulus several in different sessions. So, and usually the patient improves. And so, this electroconvulsive therapy is one of the oldest and more potent. But then there's Transcranial Magnetical Stimulation, or TMS, that nowadays approved to treat depression and obsessive compulsive disorder. 2008 it was approved to treat depression. In 2018 it was approved to treat obsessive compulsive disorder. So, and it's a different technology because it's based in electromagnetic field that so we have this coil. When the electricity passes through the coil, it creates this electromagnetic field, and when we approach this coil to the head, it will change the brain activity and transduce electromagnetic activity to electrical activity, and it stimulates this brain area. And it's also very, very, very potent, very effective to treat depression and obsessive compulsive disorder. Then we have another technique. It's called Transcranial direct current stimulation, or TTCS, that is based in direct current applied to the head, but it's a current that continuously goes through the brain to the skull and reaches the brain and stimulates specific areas. Although it's not formally approved by the FDA to treat specific psychiatric disorders, there are a lot of clinical trials going on right now, and some with great results, and possibly in the short term we will use those techniques as well. But we have other techniques, for example, the vagal nerve stimulation to treat, for example, epilepsy, or to treat some types of depression. We have this trigeminal nerve stimulation that can be applied in the nerve branch of trigeminal that is here in the forehead. So currently there are a lot of other brain stimulation in experimental phase, like near infrared, that is being tested as well. But then we have this deep brain stimulation. Deep brain stimulation is a very elegant procedure. It was introduced some decades ago by the a French neurosurgeon called Benabid that based in the work of DeLong in the terms of neuroanatomy and neurophysiology. And what they did, what the Benabid did was to stimulate a specific brain area in patients with tremor, for example, in the beginning, with a frequency around 100 hertz. And we realized that the patient that was, with tremor, that stopped to having tremor, and then he moved to use the same technique to treat Parkinson's disease, stimulating another nucleus called subthalamic nucleus. But what is interesting, because I worked I study in the University of Lisbon and in the Lisbon Medical School, where this neurosurgeon and scientist called Egas Muniz studied, and he came up with this idea of lobotomy. Obviously nowadays not applied, but in terms of scientific approach and the scientific idea, it's very important because it introduces the notion that psychiatric disorders has these organic or structural or functional locations in the brain, and if you change change this abnormal activity, we can improve those disorders. So deep brain stimulation currently used with this high frequency. It's an evolution of this idea of Egas. So deep brain stimulation is used in neurology to treat tremor, to treat Parkinson's disease, for example, and there is a lot of other disorders being used. In psychiatry, the deep brain stimulation can be applied to treat other disorders. For example, a group of several groups are using deep brain stimulation, but Ellenberg and Lozano's group, they started using deep brain stimulation to treat depression, although it's not approved by the FDA. It was just an humanitarian exemption, but with some preliminary results. And they just target a specific brain area. In terms of depression, the area, it's called the area 25 of Rodman. It's function like a white matter hub, where a lot of fibers goes, it crosses, and then stimulating that area, it can improve the mood of those patients. Contrary to Parkinson's disease, where there's a lot of videos in the internet. You can see this patient with Parkinson's disease shaking his hand, and when they turn on the stimulator, the patient stops shaking his hand. And in depression, sometimes what happens is so during the neurosurgery, stereotactic neurosurgery to implant the electrodes, the patient is awakened, and he can feel the difference in terms of moods, being more sad or more happy when they turn on or turn off the spinal cord surgery. And then it's an interesting situation. We're approached by a journalist, and the journalist asked her, aren't you feeling not human with this deep brain stimulation device? And the patient answered, when I was depressed, I was not feeling human. So it's just to show that our mood, our behavior, it's controlled by some electricity in our brain.
Absolutely. Yeah, it was interesting the way the things journalists come up with, but yeah, no, it's nice to hear sort of the patient perspective and sort of the quality of life stuff that comes out of this. It's really fascinating. So moving from the sort of rather cutting edge area, going a little more futuristic now, you had this fascinating paper that you published a couple of years ago in Frontiers of Psychology, entitled "The Hypothesis of Connecting Two Spinal Cords as a Way of Sharing Information Between Two Brains and Nervous Systems." We talked a couple of years ago when this paper first came out, and it struck me interestingly, at the time, there was a lot going on with regard to so-called heterochronic parabiosis experiments between animals and connecting vascular systems of a way to get different factors from an old mouse into a young mouse and so forth. This kind of strikes me as a very interesting sort of nervous system parabiosis type work. Obviously, maybe the press might have caught on and said, oh, wow, we're reading minds and stuff. There's a lot of really interesting work here potentially in terms of not just studying the interaction of nervous systems, but as you were saying before, the spinal cord is this highway. Can we move information around for different therapeutic purposes? Obviously, it was a hypothesis paper at the time. It's bleeding edge. You're going to be working on it moving out the next couple of years. Talk us through this, of where you see this type of work sort of going, and what are some of the sort of the short-term deliverables beyond, transferring memory between brains of humans one day.
Okay, so I moved back to when I was at the lab doing the experiments to stimulate the spinal cord to treat epilepsy. Mm-hmm. So I was using to use this protocol. I had to base on the work I was doing in the spinal cord stimulation to treat epilepsy. The animals were the same. The electrodes were implanted in the brain and the spinal cord. So it was, for me, it was not difficult to do that. And let's contextualize that we were in 2014.
Okay.
Just one year after the publication of the paper to connect brain to brain. So so I just thought that it might be possible to send information from one animal to another animal through the spinal cord. Okay. So, and I remember it was February 17, because it's the birthday of my father. So I remember I was I woke up in the middle of night with this idea, and I just jot down the schematics, and I went to the lab. I talked to an electronic engineer and asked him how I would build this wire to connect the spinal cords. And then the first wire I built, that wire, it was quite a rudimentary one, but it worked. So then I set up the experiments, and I have this rat with brain and spinal cord electrodes, and then I injected the rat with PTZ. And when I had the rat started to have this seizure, I connected this rat to a second rat, and this rat has this brain activity measured in a computer. And it was quite surprising that the second rat has this brain activity from the first one. So at the beginning, I didn't tell anyone, because I thought, it might be a random effect. So maybe I should repeat this experiment a couple of times. So I did that, and indeed it was a very strong signal. And I had this protocol, the paper, the protocol is in the paper, and anyone can replicate the protocol, because it's quite strong signal. It will have the same effect. Unfortunately, at that time, my supervisor asked me to leave the lab, and I stopped the work in spinal cord stimulation to treat epilepsy. But I showed him the spinal cord connection. He was not interested. So I believe that I would deserve to have this data, but it's his call. So then I came back to Portugal, and a couple years after leaving, 2 years after leaving the lab, I talked to him. I told him, okay, I was planning to publish this paper as a full paper, as a original paper. Would you accept? And he told me that he was not interested in publishing that results. And I believe that it would be a good idea to publish, but it was his call. He didn't want to, so I decided to publish the preliminary results as a hypothesis.
Mm-hmm.
Yeah, and the paper was had some modest impact, a lot of visualizations, and they raised some questions because of the way the review was done, but from researcher from the University of Lisbon and so forth. But clinically, it was, in terms of science, basic science, it was very strong results. And a couple of years later, a lot of research around the world they are publishing papers where they inject information in the brain via the spinal cords, including the research from the lab I was in the So the protocol is strong, the procedure is okay. However, it was published as an hypothesis. So, but clinically, scientifically, it's a quite good results. And you can see the brain. The activity going to the brain can go directly brain to brain, or can go via the spinal cord as well. It's a very, very potent highway of information, and the potential of application, it's almost infinite. So maybe in the near future we can, came up with different applications of how to approach the brain via the spinal cord instead of direct to the brain.
Yeah, and some of the things, we've done some episodes on brain-computer interfaces and sort of how you get things into the brain, and it only makes sense that if there is some pathological signal in one organism, that if there's a non-pathological version of that signal and there's a way to transfer it, there's a whole sort of range of new possibilities, whether you call them neuro re-education or whatever the terminology may be. But it is as we've been in touch, I've always been fascinated by it, and I think you show real in the world of science, where everyone's so risk averse nowadays. It's nice that you put the hypothesis paper out there, and at least you get the thoughts out there and show the preliminary data, and it's. This is where everything starts. Obviously, a lot of people complain about stuff on the bleeding edge, but I think you're on a great path with this one. And just
you can raise some ethical questions as well as all brain-machine interface or brain-computer interface raises. But it depends how the technique would be used. Obviously, for example, the internet has a good application and bad applications. It can be used for terrorism, for example, but we are here, for example, discussing science, and there are a lot of great application. So I think that this is another area of that's called neuroethics, where it should have a lot of regulation in the future. But the potential of application of this area is huge. Even in psychiatry, we use in neurology, it's used. We can stimulate the spinal cord transcutaneously. It can be invasive, like we do to treat patients with chronic pain, where there is a surgery to implant the electrode in the spinal cord. But it can be done through the skin as well. So it's not that potent, but it works at some level. And there's a lot of clinical trials going on using transcutaneous spinal cord stimulation. So the spinal cord stimulation is this can be a new highway how we can reach the brain. And the information is quite plastic because there's a lot of plasticity. And the information goes to the brain, and it reaches the cortex. It's not only the the brainstem or the basal ganglia. It reaches the cortex, so it can be very, very, very potent as well.
While I have you, I know that this is not this is previous research of yours, not what you're focusing on now, but I just have to ask because we're in this very unique world right now of COVID, everybody at home, especially all the children online school 8 hours a day, staring at a computer. A couple of years ago, you did some studies on blue light and glass use and sort of potential connection to neurological disorders. Any interesting feedback here in almost in 2021 about how much we should be sitting in front of our computers, and any interesting, beyond the sort of the blue blocking glasses, any interesting insights as we're in this?
Yeah, this idea of the blue light blocking glasses. It's being used to treat in clinical studies. Okay, it's not yet used in day-to-day practice. There are some researchers from Norway that are using these blue blocking glasses to treat or at least to study the behavior in many patients. So, for example, they are very hyperactive. They don't have necessity to sleep, so they have decreased need to sleep. They have racing thought. They can have delusional ideas. They have euphoric mood or irritable mood. And then what happened when they use these blue light blocking glasses, it will filter these wave, the lights in the waveform, the blue waveform or frequency. And this light, what do in the brain, it's this blue light will decrease the synthesis of melatonin, that is the hormone to sleep.
Mm-hmm.
So if we has continuously being exposed to light, for example, from our mobile phone or the computer or the television, we will not have this peak of melatonin, so we'll keep awake. And the objective of this blue light blocking glasses is to stop this cycle. And after, for example, 6 p.m., the patients would use the glass until 8 a.m. And when they are in the manic phase, they will improve because they sleep better, for example. But what is interesting is the opposite is also used in psychiatry as well to treat depression.
Mm.
So they use lights, for example. Some clinics use light to treat patients when they are depressed, and obviously they get better. But in bipolar disorder, there are some studies showing that these blue light blocking glasses might be an add-on treatment. Obviously, the patient has to take the pills of lithium, of valproate, or other mood stabilizer when they are manic, but they can use the lights. Actually, I recommend my patients, some of my patients, they do use the blue light blocking glasses but I explain to them, okay, this is not a device approved by the FDA. This is an add-on treatment. You can add this treatment to your therapeutical with your therapy with lithium or valproate or olanzapine or other drugs you use it to treat mania, and they do obviously get better. And simple by reducing this blue light blocking activity, blue light activity. Some mobile phone has this application to, I don't know if yours have this. There's an app in the mobile phone to block the blue light.
I don't know.
Yeah, I think you can.
I just leave it over there.
No, but you can activate. You can activate. You can activate, but it won't only work for your mobile phone. It does not work, for example, for your television.
Sure.
Unless your television has this app, this smart TV, this app. But in the computer, you can also use this activity to block the blue lights. As I'm talking about bipolar disorder, let me tell you something. I started talking about epilepsy, and there's bipolar disorder is quite similar to epilepsy in terms of physiopathology or etiopathogenesis.
Okay.
It seems, a lot of researchers are exploring this overlapping between bipolar disorder and epilepsy. As you can see, for example, the anticonvulsant like valproate or carbamazepine to treat epilepsy and to treat bipolar disorder. Although lithium, that is a mood stabilizer, does not treat epilepsy. No one knows why this happens. And then we have these changes in the ion channels that happens in epilepsy, that happens in bipolar. And then we have this, the evolution of the disease is by peaks. So you have a peak of mania or hypomania or depression, then you have a normal period, and then you have another one. In epilepsy, it can work like that. So you have this ictal phase, and then so there's a lot of overlapping activity or etiopathogenesis between epilepsy and bipolar disorder.
Very interesting. Very interesting. Amilcar, typically on the show, we come back to the guest and we sort of ask a little bit about the other people that helped get them where they are today, mentors, influencers, professors. At this point in the show, anyone specifically that you want to mention, shout out to, that has been along the ride with you as you've been going down these rather fascinating areas of clinical exploration, please have the floor and name, talk, shout out to as many people as you want.
In the beginning, to begin with, I would like to highlight my parents, mainly my father. It was a big influence in terms of mental attitude towards adversity, and it was just stimulating me to go forward and try new stuffs. And also my mother was a very kind person that unfortunately passed away. But then my family, I was a very happy kid in a very happy family, and I think it was a good base for what I would go through later in life. And then when I entered the university, I will try to do this sequentially, not to forget anyone. As I said, Antonio Damasio was a good influence for me because of his work in the conscious, in the books he published. And I remember as well in my university, when I was in second or third year, there was a very high profile neurosurgeon called João Antunes. He unfortunately passed away a couple of years ago, and I was influenced by the classes, the talks he gave at the university, and stimulating us to go to this area of neuroscience. And then I entered during my medical course. I had this extracurricular classes in psychiatry. I remember one professor called Marco Paulino that gave us, we use it together at the weekends to discuss a lot of things. So it's like a balanced group for students, and I started to feel that maybe I would come to psychiatry. So I started to become in love with psychiatry. And then a lot of different psychiatrists during my course, George Antonio Barbosa, Daniel Sampaio, for example. There was some psychiatrists that influenced me at the university as well. And then I entered the neuroscience, Professor Ana Sebastião, Professor Joaquim Ribeiro as well, and Maria José Diógenes as well. So great scientists with whom I worked. And then I entered my residency in psychiatry. Residency in psychiatry was very important. I had to thank my tutor or my supervisor, Joaquim Gago, as well Miguel Talina, Miguel Xavier, Bernardo Correia. So those were some of the psychiatrists I worked close during the residency. And then obviously I have to thank the Nicolelis Lab to receive me, although we have, unfortunately we had some questions that, it wasn't happy, but I learned a lot there, and I'm grateful for this opportunity to learn cutting edge techniques of brain to brain machine interface, and also to thank Mikhail Lebedev that worked there, and with whom I worked. I learned a lot. So there's a lot of people that influenced me during these years, and I'm grateful for having this opportunity to work with them and learn with them.
Wonderful. So for everybody that's going to be watching this episode or listening on the podcast networks, you've been listening to Dr. Amilcar Santos, practicing psychiatrist at the Hospital Via Franca de Xira in Lisbon, Portugal, also a lecturer at Nova Medical School in Lisbon, doing really amazing things in neuromodulation, neurostimulation, brain-computer interfaces, psycho-re-education technologies, and moving forward on some really cutting-edge work in the neurosciences in the coming years. Amilcar, it's been a real pleasure having you and having you share your knowledge with us on this episode, and really wishing you the best with everything moving forward. Just really insightful and inspiring, and keep up the work, and best of luck with everything you're going to be doing with it.
Thank you, Ira, for having me here in this show, and for giving me this opportunity to share at least some of my work with the community.
Absolutely.
And congratulations for this show. I enjoyed it very much. I watched a lot of episodes, and you interview people, very interesting people with different background, but working on quite amazing areas. Yeah, congratulations.
Appreciate that.